Welcome to the Cervical Cancer Survivor Series. I'm Martha Kempner with the American Sexual Health Association and the National Cervical Cancer Coalition. We recently reached out to survivors across the country to hear their stories of diagnosis, treatment, and survivorship, and get their advice for others whose lives are impacted by this preventable disease. We also talked to providers in the field to answer questions about screening, prevention, and treatment. In this episode, we speak to Barbara Moscicki, a pediatrician and HPV expert. Dr. Moscicki explains cervical cancer screening in detail and helps us understand the follow-ups we may need if we have an abnormal result. She also talks about the importance of the HPV vaccine and the possibility that we could eliminate cervical cancer. Thank you so much for joining us. Can you introduce yourself and tell us what your experience is with cervical cancer prevention and diagnosis?
Certainly. So I'm Barbara Moscicki, and I'm a pediatrician. I'm currently at the University of California, Los Angeles. I have been doing HPV research now for close to 40 years. A lot of my experience, we had what we call a cohort study, and that we followed about 1,500 women over a span of 25 years. And during this time, we were able to actually define the natural history of human papillomavirus, and I'm going to refer to that as HPV from now on. And we were able to show that the virus can be transient, but those persistent infections would go on to what we call a precancer or cervical interepithelial neoplasia. And those precancers are what we got very interested in. How do we go and how do we prevent these lesions from happening? And then how do we diagnose these precancer lesions because they can be treated. I also have experience in that we did informational tablet education, and it really told women all about how often you should have cervical cancer screening. And for those that had an abnormal test, we went on to really help explain through visual effects what the next steps would be. The referral system, the referral to what I'm going to refer to as colposcopy, where you actually make the diagnosis. I'm currently also involved in screening in those women living with HIV. So I have a widespread interest in all sorts of prevention of precancers and cancer. Thank you.
Thank you. I just want to start. You mentioned this. Can you tell us how often should somebody be screened for cervical cancer? I know the guidelines feel a little bit more confusing than they used to be.
Yes, they are. As you know, the U.S. Preventive Task Force and the also what's referred to ASCCP and ACOG currently support starting screening at the age of 21 years of age through 65. In that, there are a couple ways you can get screened. One is the old-fashioned way, I'm going to call it, and that's getting the PAP, which we really refer to now as cytology. And that PAP test or cytology, it's recommended to have that every 3 years. If we move on to a different type of testing, that is, you have a PAP plus HPV testing, we call that co-testing. And so not only are you taking cells off the cervix and looking at them under a microscope, you're also testing for the virus that is the cause of cervical cancer. And this co-testing is every 5 years. More recently, we've moved to where you can just do the HPV part of the testing. So you do HPV testing because you're not going to get cancer if you don't have HPV. And if that test is then positive, what we refer to is as a reflex test. And that reflex test can be cytology, that they actually keep a little bit of the cells. So they first test them for HPV. And then if that's positive, they then put those cells on a glass slide. Again, refer to that as cytology or a PAP. And then if that's abnormal, depending on that, they would make a management referral. In that testing, all you need is HPV first. And if it's negative, your next test is in 5 years. That's how sensitive, that is how good HPV is for telling you whether you don't have disease. So if you're negative, great chance you don't have disease. We'll see you in 5 years. So we have the cytology testing only. That's still there. And that's every 3 years. Once you add the HPV testing, you can go to every 5 years.
And do you get to choose as a patient? Do you really choose what kind of test you get, or is it more you choose your provider and your provider chooses what test they give?
It's usually the latter. And that has to do with, the complex system of how their laboratory is set up. Primary HPV testing, what I talked to you about, is not available at a lot of laboratories currently. So you're kind of stuck with, kind of what that they offer. Right now, co-testing is the more common one. I did want to go back to 1 second because you said there's some confusion. American Cancer Society came out with doing the primary HPV testing, but starting at the age of 25. So right now, there's a little bit of difference about when to start the screening. But to be honest, I think whatever that provider is the most comfortable with is going to kind of make that decision. And as I said, it often is provider initiated on what they have to offer.
And there are new guidelines from the Preventive Health Task Force that are under consideration right now, yes?
Yes, but they still continue to start at the age of 21. They have not moved that needle.
Okay. And at 21, you're not getting an HPV test, though, right? At 21, you're getting a cytology or a pap test?
Correct. You get a cytology test. They recommend 21 at least to 25. And then at the age of 25 versus even 29, you can go to HPV primary screening. I think the whole world, and I'm going to say the world, it's certainly US, but the whole world is going towards this primary HPV testing because you can save money. If you don't have to do the cytology, you save money. And if you have a negative test, that person comes in 5 years. So overall, I know there's going to be this little window where we have a few differences on when to start screening, but everybody else is kind of on the same page that primary HPV testing is going to be a more cost-efficient method to go forward, but options are co-testing as well as cytology.
We used to get pap smears or pap tests, starting at 18, or they said as soon as you were sexually active. Why is it that we're pushing them back a little bit now?
Mostly because when you're young and you are first exposed to HPV, you have a 90% chance, or 90 out of 100 women are going to clear this virus. And by clear, we suddenly don't detect the HPV any longer. And so what we don't want, what we know also is that the natural history from infection to cancer, 15 to 20 years. And so what we don't want to do is do harm to women and do a lot of unnecessary procedures. So what we know is we have a window. We have a window to observe a woman. You get an infection and it's going to go away. And so we don't want to start interfering during that because it's just going to cause basically a cycle of a woman constantly coming in when she doesn't need to. And so we pushed it back knowing that you're not going to see cervical cancer under a woman under the age of 21, unless it's extremely, almost maybe genetically predisposed. There's some incredibly immunocompromised condition, but we're just really not seeing cancers, cervical cancers, sorry, under the age of 21, which is why they push the needle to say, okay, you don't really need to start screening until around the age of 21.
So if I go in and I get a primary HPV screening, so I only get the HPV test, what does it mean if it comes back positive?
Really important question, because it does not mean you have cervical cancer.
Very important.
This is a really important point. It is a screening test, which means now we need to do a second triage, or what we call is like, okay, you're positive. I know you have the virus, but is it a problem? So it now becomes a little more complicated in that if you have what we call a certain genotype that I'll refer to HPV 16 and 18, we know that those are kind of all the HPV types that can cause cervical cancer, this one seems to be the more aggressive one. So if you're HPV 16, 18 positive, they will then refer you on to what we refer to as colposcopy. If you are positive for these Other types, well, often what they'll do then is that what I was referring to earlier, a triage test. So then they might do a pap smear. They might also do a new kind of testing called dual stain. And if those come back positive, then you would go to colposcopy. But if they're negative, they'll say, I'll see you in a year. I'm not really worried. So even having a positive test can be a little bit more complex, but it's pretty much easy to say that the majority of those women who are going to be HPV positive and even have a colposcopy do not have the precancer. So that's why I was saying there's the natural history here gets that you're going to clear it, but we don't know exactly when.
So I want to ask you about colposcopy in a minute, but before we do that, let's just also talk if you did get a pap test and it came back abnormal, what does that mean?
The pap tests, they're actually looking at the cervical cells, and they're the ones that you scrape off. And what they're looking is to see if they look like something is not quite right. That is, the cell itself looks very different than a normal cell. Like its nucleus might be enlarged. They might have other changes within the cell, and they're kind of like, ooh, that may look like a precancer lesion. Or it may even look like cancer. That would then trigger, again, a referral to colposcopy. But they're actually looking at the cells themselves, and usually that would be an effect of HPV causing those cells to become abnormal.
So what does colposcopy do? What is it?
So colposcopy is basically a microscope on wheels. What it does is the provider would actually put in a speculum like in a normal exam, and they then put something like basically diluted vinegar. It's called acetic acid. They put that on your cervix, and what it does is if there are those abnormal cells I just talked about, it causes those cells in the area where those cells are to turn very white. And when then they look through the microscope, they're looking at your cervix directly, and they're looking for these areas that are white. And they also look for different changes in what I'm going to call the vascularity, or how the blood vessels look, because a precancer lesion is growing really fast, and what it needs is more nutrients. And so you get the different type of blood vessels that come in, and they make a pattern. Sometimes they look like a mosaic. Sometimes they look just like little pinpoints. And that the provider then will take a sample of that tissue. They have like a little special instrument, and it takes literally a little snip of that tissue. That tissue then will be sent to a pathologist. They cut it up into small, thin slices, and then they look at it under a microscope. And that allows them to look to see if that area is a precancer or a cancer based on how it looks under a microscope. And that's how really you make the diagnosis. It's not with HPV. It's actually looking at a biopsy or that tissue sample and making that diagnosis, a precancer or cancer.
Before we talk about what happens if it does come back as precancer or cancer, does a biopsy hurt? Does colposcopy hurt?
In general, colposcopy itself does not hurt. It is a speculum exam. So if a woman's very sensitive to having a speculum exam, it may feel uncomfortable, but that would be no different than the routine. Putting on the acetic acid, I would say 95% of women do not feel it. But if you had some irritation, it'd be putting, vinegar on an open wound doesn't feel great. As I mentioned, it's diluted vinegar, so it's not as strong. And I would say the biopsy, my experience, 50% of women don't even know I've taken the biopsy. They're like, really? And then I would say 50% of women say, ouch, that really was uncomfortable. It can cause some cramping. Once you do it, the cervix kind of reacts to also having it, and then they can have, some cramping. So I usually at least prepare women for that they might feel this, kind of cramping in the cervix, or they might feel what feels like, a shot, I'm going to say, because it's hard to say. You don't know. Most people don't know what it likes to take a little piece of tissue.
Right.
And the cervix, though, does not have the same type of innervation than like your face or your skin here. Like if I took a biopsy out of your skin here, you would definitely feel it. On the cervix, as I mentioned, because the innervation really isn't the same, and thank goodness, otherwise, how would we even have babies, right? I mean, that cervix goes under a lot of changes.
Epidurals, but go on.
Yeah, epidurals, well, yeah. But again, the cervix, because of its innervation, has responds very differently to getting a biopsy than it would in your face or your skin here.
And then let's say that the biopsy first comes back pre-cancer. What do you as a provider usually recommend? I mean, obviously it would depend patient to patient, but what could a patient expect?
So this is where we have a histology 101, a change called CIN1. We consider, that's HPV. It's going to go away. We don't have to worry about it. So when I refer to a precancer, it's really what we refer to as a CIN2 or 3. And again, these are grades that your pathologist will give, and it depends on how much of the tissue is abnormal. So if you have a CIN3 lesion, that's the one where you see the most abnormalities, but it's not invasive cancer. It is recommended we treat those. Most common treatment in the US is actually removal of the tissue. So we have a procedure, it's called LEAP, and basically it removes that lesion and a bit of the surrounding area. And again, that will go off to a pathologist just to make sure there's no invasive cancer there. They want to really confirm the diagnosis. If it is a CIN2 lesion, that also gets like where you want to have more kids. And why do I ask that? Because sometimes that procedure I talked to you about, the LEAP, it's small, but there is a risk of what we call premature delivery, that you would, go into labor prior to the full 36 to 40 weeks. And so because of that small risk, we say, oh, if you're still interested in having kids, here's your choice. I can go ahead and treat it. That risk of premature labor is pretty small, but it's a risk. Or we can watch it. And then if you watch it, we basically bring the woman in every 6 months. We look at the lesion. If we think it got worse, we'll retake a biopsy. If it's gone, then we just, again, kind of watch it. We do another, HPV test or a pap smear, and we can follow it for up to 2 years. If 2 years, that lesion is still there, we now think the risk of it going on to invasive cancer outweighs the benefit of watching it any longer, that we go ahead and would treat that lesion at that time.
So is this something your gynecologist can do, or is this something you have to go to a specialist for?
Again, great questions. I would say that in some practices, it's a gynecologist who feels very comfortable in biopsy, follow, and doing this LEAP procedure. Other practices, especially I believe a lot of healthcare providers or like nurse practitioners, they're most likely then to refer a LEAP procedure out. And those LEAP procedures can be done again by the gynecologist or a gynecologist oncologist. So again, it depends how the hospital practice is set up.
So I'm guessing that if it did come back as cancer, you do have to go now to a gynecological oncologist.
Absolutely. Once you get the diagnosis of invasive cancer, that would be taken care of by a specialist.
And do you have any advice to someone on how to find a specialist in their area?
Well, once again, I believe strongly that if you're going to be doing biopsies, if you're going to be doing LEAPs, you have to have a set of referrals in case it's invasive cancer. So hopefully that person who is your primary provider doing the biopsies and or LEAPs also has a list of providers that work in their area. I always think it's nice to get a referral. I think it's hard for myself just going to the internet and, going, I want a oncologist in the area.
I find myself relying too much on pictures. That person looks friendly.
Yeah. Well, and so I think, again, getting a referral is great. Certainly going to an academic center, if there's one within your area, is often what people will choose, or a well-known name. I'm going to throw out City of Hope. This is, again, a very well-known name, Mayo Clinic. Those are places that I think, again, one can really feel confident that they are a cancer center. And there are designated cancer centers which have actually rigorous review from, the National Cancer Institute. So that also is a place to look for, is a designated cancer center.
I want to go back a little bit to preventing HPV because cervical cancer is one of the unique cancers that we know how to prevent. And we are not maybe in a widespread way doing the best job of that. So I want to ask you, if you were an adolescent medicine practitioner, did you ever talk to people who were resistant to the HPV vaccine? And what did you say to them?
So this is unique problem, not unique to the US. I can tell you my colleagues throughout the world face vaccine resistance. There's the individual who is vaccine resistant. Those are populations that are obviously very difficult. HPV is no different to them than the measles, mumps, and rubella. It's a vaccine, and they are fearful of all vaccines. Then you have the individual parents specifically who we list. These are the ones your adolescent needs. And all of a sudden it's like, what's the HPV vaccine? And so then that requires education. And we talk about prevention of cervical cancer. We talk about prevention of oropharyngeal cancers, especially for the parents who have boys, penile cancer, genital warts. And, I have some parents who look at the kid and say, you want this? And the kid says, yes. I would say 99% of the time. Then I also have parents who simply say, well, I need to wait. And we kind of say, well, I want you to know that this is preventive. And so this is the age group, because we know we want to vaccinate them long before they have made a choice to become sexually active, whether that's through marriage or not marriage. We know that if we do it now, I need to give you less vaccines, which also the kids really like. You only have to have 2 instead of 3. That goes over big, and then, and really, talk again about them, how important it is to do it in a preventive manner. And that's before they even think about sexual activity. So I really try to separate it in this concept that, we have got plenty of time to wait because they're not going to have sex till they get married. And so I really try to back that away from saying, and no matter what, this is the time to give this vaccine. I said, because you may forget to get it later, and then it's too late. I'm here to tell you what the recommendations are for our own immunization practice that comes through the CDC. And so, we talk about that. And, at some point, you don't want to push a parent to a point where they're just like, oh, I feel like you're trying to sell me a car, And it's like, okay, well, let's talk about it the next time you come in. And, I want you to think about it. I always try to give them information from, handouts because, again, if you go to the web, I'll say immediately the dark web comes up first, and you're going to see nothing but really false information. This vaccine is extremely safe. We really, when they look through all those vaccine registries, nothing really is popping up that it's due to a side effect that's due to the HPV vaccine.
Could you just explain to us what the recommendations are for the vaccine, when somebody should get it, and how many shots they need?
Yes, the current recommendations are that the HPV vaccine, again, in the US, we have one vaccine that's available. We refer to it as the nonavalent or Gardasil 9. It has coverage for 6 and 11, which causes genital warts. And then it has currently 7 other types that are associated with cervical cancer and anal cancer as well, and oropharyngeal cancer. So all the cancers have at least, a good coverage with what's in that vaccine. So it turns out the younger you are, the less number of vaccines you are. Why? Because young people have really good immune systems. So the current recommendation is to target 9 to 12-year-olds. American Academy of Pediatrics has pushed that down to the 9 age level. And currently the CDC is 11 to 12, but they also say you can start at 9. And at that age, you only need 2 vaccines, basically 6 to 12 months apart. Once you hit the age of 15, the magical age of 15, you are going to need 3 shots. And that's recommended at 0, 2, and 6 months. So in that sense, once you're kind of 15, you're supposed to get the 3 shots because your immune system already starts, I'll say, waxing and waning a little bit, and up to the age of 26. We also have in the US allowed for, again, boys and girls up to the age of 45, but between 26 and 45, it's like a decision-making process between you and your provider. Yes, you might have been exposed to some of the HPV vaccine types, but maybe not all of them. So you still will get protection. So I'm going to go back to why do we go 9 to 12-year-olds? Because it works really well before you've been exposed to any of those types. Once you have a type and it's persistent, this is not a therapeutic vaccine. It doesn't help you clear that virus, which is really important for parents to wrap their head around, that you really want to do that before they get exposed to any of those HPV types.
But if someone's listening who didn't get it as a teenager, let's say they're in their 20s now, this is something they could go and talk to their provider about and possibly get now, right?
Yes, that's what I said, up to age of 45. In fact, the CDC does recommend a catch-up. If you don't get it between the ages of 9 and 12, it is highly recommended that you get the HPV vaccine up to the age of 26, because you are going to get protection from it. It's more the after 26 to 45, where that's where we called shared decision-making between you and your provider.
So you mentioned working with colleagues around the world, and that unfortunately vaccine resistance is not unique to the United States, but we've been reading about Australia and their plan to eliminate cervical cancer with widespread vaccines. Do you know about that plan, and do you think they're going to be able to do it?
Well, our Australian colleagues certainly think that they're going to do it. So, they've already showed a huge dent into getting rid of cervical cancers, which is really amazing. They do have a school-based program. So in certain areas within Australia, they hit around 90% getting HPV vaccinated. We also know there's something called herd immunity, that you get up to around 90%. Even those that have not been vaccinated get protected. And why is that? Because you've gotten rid of the virus in 90% of the population. So when they start having sex, they're not getting exposed either. I'm not going to condone or, say you shouldn't get vaccinated, because I would like to see 100% of individuals get HPV vaccinated, because we don't know how long a herd immunity lasts or any of those other things. So 100% should be the target. Said that, I think Australia may be one of the first to reach elimination. We do have other places like, Denmark, published their data as well, showing, incredible decreases in invasive cancer in Sweden. So some countries are doing great, and they're really seeing an impact. And so this can be done. I would love to see this be done in the US.
Perfect. And I think that's a really great place to close and to say thank you so much for joining us and for sharing your expertise with us. And I know there are a lot of people listening who will have learned a lot from you just now.
Great. And thank you for having me.
Thank you so much for listening. If you want to listen to all episodes in our Cervical Cancer Survivor series, head to nccc-online.org, where you can also find a lot of information about cervical cancer prevention and screening.